Morning. Thank you for having me today. My name is Yousef Abu Asbeh. I'm a thoracic surgeon from Palestine. And today I'm presenting you our review of VATS approach to treating empyema in a pediatric age group. So as you may know, empyema is a accumulation of pus within the pleural cavity. It's classified into 3 stages based on the natural history of the disease. And in the recent, unfortunately, in the recent years, we are seeing more and more drastic increase in the incidence and prevalence of the empyema in the pediatric age group, particularly under the age of 5. And unfortunately, till now, there is no consensus about the proper approach in regard to the time and approach for dealing with the empyema. In the past, we used drainage only for patients who failed to the antibiotic treatment, but we are seeing that the VATS are gaining more and more popularity dealing with this disease. And the safety and efficacy of pleural drainage by VATS or by new methods like pigtails and other methods has been demonstrated in several studies. But we still lack of proper recommendation regarding the proper timing for this intervention. So we have reviewed our data retrospective, and we have done retrospective analysis for 72 patients between 2021 and 2024. And they have been divided into 2 groups. Group who underwent VATS, there were 51 patients, mostly males. And the second group was pigtail insertion with or without fibrinolytic therapy. Our surgical approach includes uniportal VATS, usually in the 5th or 6th intercostal space, between the incision size range between 1 and 2.5 centimeters. And there were no conversion from VATS to thoracotomy. And we used the ultrasound to identify the incision site, depending on the most dependent site, site of the most collection. We relied on the blunt dissection. We don't like the sharp dissection for the empyema, and we don't like the anatomical resection for empyema. Even in the worst case of necrotizing pneumonia or lung abscess, we try to preserve the lung parenchyma, and we see that these are going to heal over time. We did not use lung isolation for the patient less than the age of 2 years. For the patient who were older, we used selective lung intubation. And we like the soft tissue retractor. This is a very helpful tool for the VATS. Our results showed that in regard to the time to afebrile, duration of chest tube placement, and length of hospital stay and post-operative antibiotic were significantly better in the VATS group. The operative time was longer in the operative arm. Our tips and pitfalls. We leave at least 2 chest tubes for these patients. This is very helpful in case one of the tubes got clogged, and this is very, very helpful also for the irrigation. We like to perform daily, almost daily or every other day, generous irrigation. This will help you to achieve sterile pleural cavity faster. And we also like the fibrinolytic therapy. The most popular is the TPA. It's very effective, mainly with the pigtail group. And please expect delayed chest X-ray improvement. This is very frustrating. You spend the time, doing a very good decortication, and next day you see the X-ray. There is no significant changes. Don't get frustrated that the X-ray will take time to improve. And deseptation sometimes is enough, especially in the stage 2 of the empyema. We rarely need to perform decortication, and please don't do any anatomical resection for the empyema. And lung abscess is not a contraindication for the empyema. Thank you.
Thank you for your nice presentation. Dr. Faiza, one question. Dr. Adel.
No?
Yeah,
okay.
Now we can.
Now we can. Okay. So thank you very much for your presentation. That's impressive. Number of patients were large. I can see that, like the comparison. My question would be, in the part that you had to do VATS, did you need to go and do a recurrence another time? And in any of these that you had VATS, did they go for fibrinolytic medication or treatment?
That's
because
right.
you had two arms, right?
Yeah.
So these two questions.
Yeah.
Thank you.
So between the 21 patients that we have done pigtail insertion for them, or interventional radiology drainage for them, to 11 have moved to the VATS side.
Okay.
Unfortunately, so because we see that, especially in the advanced stage of the empyema, there was a lack of the resolution of the empyema. So yeah, and in regard to the fibrinolytic therapy, yes, we also used it, I think, in 9 patients, and that depends also in the lack of the progression. But we try to avoid the first week after the surgery to avoid bleeding.
Thank you very much.
You're welcome.
Okay. Dr. Adil?
So thank you very much, Doctor, for your presentations. My question is why, you are leaving the lung tissue, necrotic one, not drained. You are draining, as per your presentation, only the external collected fluid. But the lung tissue, the necrotic one, why are you not debriding that one?
Yeah. So thank you, Dr. Adil, for your question. So again, we try to avoid any anatomical resection. We don't do lobectomy, and definitely we don't do any pneumonectomy. But we try to do a careful debridement for the necrotic tissue in case of necrotizing pneumonia or aggressive lung abscess. But what I'm trying to say that we don't like to, because once you will be surprised how fast these kids are improving after bypassing the time of the acute event. This is why we just try to preserve them a lung parenchyma.
That's fine, I can understand that one. There is no indication for a lobectomy.
Yeah.
Only debridement, the necrotic tissue. The patient will have a bronchopleural fistula for a few days, then it will heal spontaneously.
Yeah,
But
we do debridement for
the lung tissue.
Yes,
Okay, so that was not clear in your
definitely.
presentation.
Yeah.
That's fine, thank you.
Okay. Thank you so much.
Thank you very much. Thank you.
Next talk.